My name's Dr. Ken Gorson. I'm a neurologist at St. Elizabeth's Medical Center and professor of neurology at Tufts University School of Medicine. So I think we'll get started this morning. I want to thank all of you for coming out on a beautiful Saturday morning to hear me speak on CIDP. What I'd like to do for the next hour is give you a nuts and bolts presentation about what this disease is, how neurologists make this diagnosis, and how we go about treating it and making decisions about, do you have the disease or not? And if so, how is it that we make this diagnosis? And then how do we go about trying to make patients better using proven therapies, proven protocols to treat the condition? And then what happens if the treatments don't work or patients have side effects? I was speaking with Barbara earlier, just a few minutes ago, and she was telling me all sorts of stories about internet information she's reading and patients who are blogging on the internet, and they're writing all sorts of bizarre things about their experience. You know, I've had Guillain-Barré syndrome, and I'm getting plasma exchange for 20 months. Well, there's no science or reason to give people plasma exchange for 20 months. And so hopefully today I can dispel some of these notions in relation to the management of CIDP. So there are my disclosures. So where do we start with this condition? I think a little bit of historical background can be helpful. So that, physicians don't discover diseases. They are around for God knows how long, centuries perhaps, even longer. But in the modern era, smart physicians start looking at patients carefully and start putting the stories together. So Guillain-Barré was written about by doctors Guillain-Barré and Stroll in 1917, and about 50 years later, a fellow named James Austin at Columbia University came upon several patients who had an unusual pattern of peripheral neuropathy. So most peripheral neuropathies or polyneuropathies tend to affect the distal aspects of the limbs with numbness or tingling and weakness in the feet, and that's because the longest nerve fibers are affected first, and then shorter nerve fibers are affected later. But in the two patients Austin described, these folks had a different clinical pattern. They had involvement of the proximal limbs, the shoulder girdle muscles and the hip girdle muscles, simultaneously with the distal limbs. So that was a really unusual clinical pattern. Most patients with typical distal neuropathies have loss of just the ankle reflexes, and that's a hallmark of peripheral nerve disease when the doctor hits your Achilles tendon and there's no reflex there. But in these two patients, they lost all of their reflexes. So that was kind of unusual as well, generalized areflexia. EMG was just in its infancy then, but EMG was helpful to distinguish between nerve diseases that affect the nerve itself, which is called the axon. If you think of the nerve as the copper wire, the copper part of the wire is the axon. The insulation part is the lining of the nerve called myelin, and I'll come back to this in just a few minutes. Most neuropathies were axon neuropathies, where the copper part of the wire was damaged. But in these two individuals, the EMG showed that it was a myelin problem, and he called that a demyelinating neuropathy. He also found that the spinal fluid protein level was elevated in these patients, and that was unusual in most neuropathies, but was actually described in patients with Guillain-Barré. And lastly, and probably most importantly for patients, these individuals had a dramatic response to corticosteroid therapy. And the precursor for corticosteroids at this time in 1958 was a compound called ACTH, which is a hormone that all of our bodies make that stimulate our adrenal glands to make our own cortisone. And so some of these individuals were so weak they were bedbound, they were given ACTH and had unbelievable recovery, recovered to walk and almost returned to normal. And then the ACTH was stopped and the patients relapsed again. And so they had this chronic relapsing course. And that's what he had called this recurrent polyneuropathy and their corticosteroid treatment. This was the first description of CIDP in the modern era. And since then, there were a series of case reports, individual patients or series of patients, 5 or 10 patients, followed by well-respected neuromuscular experts in their field at different institutions throughout the world. So there's Austin's first paper in '58. P.K. Thomas, a very famous neurologist in Britain, described chronic relapsing Guillain-Barré. These were people who looked like they had GBS, except they'd get better, and then they'd get worse, and they'd get better, and they'd get worse, and they had a chronic disease. Likewise, Matthews described something similar and again highlighted the relevance that corticosteroids helped these individuals, and they were dependent upon steroids to stay normal. DeVivo described something similar, and then it was Peter Dick, who is really one of the godfathers of neuromuscular diseases, and in particular peripheral nerve diseases at the Mayo Clinic, who put together a case series of about 52 patients who he called CIDP, or chronic inflammatory polyradiculoneuropathy. And then later on, 2 years later, added the term in demyelinating polyradiculoneuropathy to highlight the fact that the physiology of the illness affects the peripheral nerve lining, the peripheral nerve myelin, as opposed to the axon. So what's the case definition? What is CIDP? Well, the C is for chronic, and that means it's got to be slowly progressive symptoms and findings beyond 8 weeks. And the major reason for this is to distinguish this condition from Guillain-Barré syndrome. Guillain-Barré is a monophasic illness. It comes on quickly, it progresses rapidly, the patients reach a plateau phase, what we call a nadir, and then they slowly recover, and very rarely do they ever go on to have other recurrent attacks of Guillain-Barré. The I part is inflammatory, and that has to do with evidence of inflammation of the nerves, and we know this in patients who've come to autopsy with CIDP or in nerve biopsies. We can demonstrate evidence of nerve inflammation, and we know that immune therapies that we use to treat this condition work on reducing inflammation, and the patients improve. Demyelinating refers to the findings that we see on electrical nerve studies as well as in pathology. When we look at nerve fibers under the microscope, we can actually see the myelin has been stripped off or damaged, or we have evidence of not just demyelination, but recovery of nerve function with remyelination. And I'll talk about the EMG findings of demyelination in just a few moments. So those are the hallmarks of what makes CIDP different from all the other neuropathies. It's not a common disease. It's got a prevalence of about 3 per 9 patients per 100,000 individuals. It tends to affect individuals between 40 and 60 years for a peak incidence, but it can affect children. It's been described in infants, and we've seen it in patients in their 90s. It's slightly more common in men. What is nerve demyelination? Well, if we can see here that these are the individual nerves coming down your legs into your feet and into your, I don't know if this pointer works so well now. You'll have to take my word for it. You can see the nerves coming down in the arms. And then if you look up at the upper corner there, you see the actual axon, and think of that as a wire. And then the sheath around the axon is myelin. And what happens in both Guillain-Barré as well as in CIDP is that the myelin is attacked through very complex mechanisms where there are inflammatory cells and probably antibodies that see peripheral nerve as foreign. And your own immune system is generating this attack, these antibodies, that bind to the lining of the peripheral nerve and strip the nerve away, damage or disrupt the myelin. And you would need to think about this as a copper wire. So you need the insulation for the copper wire to conduct electricity properly along the nerve fiber, along the length of the nerve fiber. If that insulation is damaged or disrupted, the electrical signal doesn't conduct properly. And in people, that translates into symptoms of weakness or sensory loss. So for example, as I move my finger here, my brain is, through neurons, is saying, move your finger. Well, that electrical stimulus comes down through my brain, through my spinal cord, into my motor roots in my neck, going down to individual named motor nerves in my arm to the muscle that moves my finger. Well, anywhere along that pathway, if the myelin is damaged, I won't be able to do that well because the electricity won't conduct. Sometimes when the myelin is so completely damaged or disrupted, the electrical conduction is blocked completely, and that translates into paralysis. And in fact, we use that term in the EMG laboratory, and that's called conduction block. So what are the classic features of CIDP? Well, weakness is the hallmark of the disease. There are classic or typical patterns of CIDP, and then there are unusual variant or atypical patterns. So we'll talk about the typical patterns first. The hallmark is weakness. So in patients who come in with numbness and tingling in their feet, right off the bat, CIDP is not high thinking on the differential in terms of a patient having that problem. The patient may complain of weakness, but more often they're going to complain about troubles they have in activities of daily living. They're going to have symptoms of disability. So they may have hip weakness that we find on examination, but they may not complain of hip weakness. They may complain of, "Doc, I can't get off the toilet. I need to use my hands. I can't stand up out of a chair without pushing off. I can't get out of a car easily. I can't go up and down stairs." If they have arm weakness, they may complain of trouble holding things or carrying things or putting plates on shelves, that sort of thing. If they have hand weakness, they're going to complain of symptoms of fine motor skill difficulty. So buttoning buttons, pulling up zippers, for women putting in their earrings, handwriting can be impaired. These are the sorts of symptoms that we listen for. Now, on examination, there should be a clinical correlation to those symptoms. So what we will find is evidence of measurable weakness on bedside testing. And I imagine all of you have seen neurologists, and when we examine you, we have you squeeze our hands, and we move your arms around and test your leg strength. And typically, we should not be able to overcome any muscle group that we test as you sit on the examination table or on the examination bed. When we can move your muscles around and you're trying as hard as you can, that tells us that muscle's not working properly. It doesn't always mean that it's a nerve disease. It could be from a stroke or some other problem. But in this context, it suggests that the motor nerves aren't working properly to the muscles we're testing. So we find on exam proximal weakness. It's usually symmetrical, so one side is similarly involved to the other, bilateral, both sides, and it's usually in the arms and legs. And that's another hallmark of CIDP, because in most neuropathies, the arms and the hands tend to be relatively spared, where the hands may be involved much later in the illness. But in CIDP, because this is a generalized disease, and all of the nerves can be affected to varying degrees, with varying degrees of demyelination and inflammation, we may find hand weakness that in fact could be worse than leg weakness. So that's a red flag for us as physicians to be thinking about demyelinating neuropathies. What about sensory features? Well, the sensory nerves are affected just like the motor nerves. So in that situation, when the sensory nerves are demyelinated and inflamed, patients have classical symptoms of numbness, pins and needles sensation, what we call paresthesias, loss of balance, leading to unsteadiness and increased fall risk, and that's a major problem in this condition. If their hands are numb, patients will usually say, "I dropped stuff. I'm holding something in my hand, the pen falls out of my hand," and it may be due to weakness, but it may be that their fingertips are numb. And so when that happens, they don't get a feedback phenomenon to know how hard to grab something. So frequently small objects may drop out of their hands. On examination, when we test sensation, we test touch and pressure and vibration and joint position by moving your finger or your toe up and down to see if you know where your joint is in space, and we'll find abnormalities. So patients will notice that they're numb, and we'll be able to test that light touch will be reduced in their finger pads or in their toes or their feet or their legs. And when we move their toe up and down, they may not know that it's up or down. They may guess or have no idea. And that frequently correlates with a sense of unsteadiness with walking, particularly if they're unsteady with their eyes closed. That's a physical finding we call Romberg's sign. Some of you may have experienced this in the shower. With your eyes closed washing your hair, all of a sudden you lose your balance. It indicates that your joint position sense, another term for that is proprioception, is impaired, and that's a function of sensory nerve demyelination. The other hallmark of the disease, as I've discussed, is the loss of reflexes. So when we tap on a knee jerk, what we're doing is we're stimulating a tendon, we're sending an electrical signal through the sensory fiber up into the spinal cord, which then connects to a motor fiber connection that then comes down to the muscle. So you tap on your knee tendon and you get a knee jerk. Well, in patients with CIDP, they lose their reflexes. And again, this has to do with demyelination such that the electrical signals are not synchronized properly to carry the sensory signal up to the spinal cord and back down, so people don't get that response. Fortunately, losing your reflexes has no clinical relevance for the patient. You shouldn't be concerned about it at all. It's just a very useful physical finding for the neurologist to tell us that you have a peripheral nervous system disorder. We have to have a disease that's more than 8 weeks, and again, to distinguish from Guillain-Barré syndrome. There are occasional variants of CIDP that can have a rapidly relapsing course that can simulate Guillain-Barré. That's very unusual. It's maybe about 5% of CIDP patients. And really what we want to do is we look for the clinical features, the historical features, and we have a pretty good idea on history and examination what should be going on, and then we need to confirm the diagnosis. And we do this with some laboratory studies looking to exclude other causes of peripheral neuropathy, like diabetes mellitus, like vitamin deficiencies, like kidney failure, alcoholic neuropathy, inherited neuropathies, and so forth. And we can usually do this by history and exam, but also sending additional blood tests and EMG testing. This is just a pattern to show you the different courses that can occur in CIDP. The top pattern is the most common, which is a slowly progressive disease evolving like a snowball going down a hill. And the slope of the progression can vary among patients. So some can progress quickly, still has to be beyond 8 weeks, but over the course of several months. Others have a very slow, very indolent pattern of progression. They really can't even tell you when the disease started. Some patients will have a stepwise progressive disease where they'll be stable for a while and then get worse again and then stable for a while. Every once in a while, we'll find a patient who has a monophasic illness that's like Guillain-Barré, except that they progress over 3 or 4 months, but then they sort of remain stable. Most of the patterns below that, where you see the relapsing remitting pattern, that's really around the issues of treatment and weaning of treatment or treatment withdrawal. So that when we make patients better with treatment and we stop treatment, the patients can relapse pretty quickly. Then we restart treatment and we make them better, and then they create this sort of roller coaster phenomenon. We really look to avoid that pattern if we can help it. What are some of the routine tests that we use to make the diagnosis? Spinal tap can be helpful. I usually do electrical studies first, and if the EMG is pretty clear and the history and the exam are consistent, I usually don't do a spinal tap. But sometimes it's helpful because sometimes it's not always clear. And so with a spinal tap, what we're looking for is an elevation in your spinal fluid protein level without a cellular response, just like what we see in Guillain-Barré. And this is seen in about 80% of CIDP patients. So not having it doesn't rule it out, but when we find it, it can be very helpful. And then EMG studies. And really what we're looking for there, without getting into the details too much, I'll show you some pictures, but the concept is to find a pattern of multiple areas of clear, unequivocal nerve demyelination that can't be explained by some other issue like nerve compression, and we need to see it in multiple different nerves, ideally in the arms and legs. And when we have that electrical combination, we can be pretty certain what we're dealing with. Now, every once in a while, the EMG doesn't help us, and there's a variety of reasons for this. But in that situation, some patients do benefit from a nerve biopsy if we can demonstrate inflammation in the nerve or demyelination in the nerve. The problem with nerve biopsies are frequently they're non-diagnostic. By the time the patient comes to us, they've had the disease a very long time. The nerve fibers, the axons, can be damaged. And so when we biopsy a nerve and they're a year or two into the illness and they've had a bunch of treatments, frequently we may just see dead nerve, axon loss. We may not see demyelination. We may not see inflammation, in which case the nerve biopsy is not helpful at all. It's the same as not doing it. But there are selected cases where we need to do it, hoping to find those abnormalities to establish the diagnosis. So this is just, I don't know how well this portrays, but this is an example of a nerve conduction study. How many of you have not had one of these tests? That's what I would think. Okay. How many of you have had more than 5? Okay, that's good. How many have had more than 2? Okay, not so good. So really you want one good test to make the diagnosis, at least in my view. There are some reasons to repeat them periodically, but I've had a lot of patients I've seen who've told me they've had 5, 6, 7 EMGs to follow their disease, which I'm not quite certain how that's helpful. In any event, what we're doing here, we're applying an electrical stimulus to your nerve, that's the median nerve, and we're recording over a muscle that nerve goes to. And what we're doing there is trying to figure out how healthy that nerve is by increasing the electrical stimulation, small shock, bigger shock, bigger shock, bigger shock, and we're looking at an oscilloscope screen that shows us a waveform. Then we stimulate the same nerve higher up and then look for a different waveform in a different location. What does this mean? So in this example, we're stimulating the nerve at the wrist. This is called a compound muscle action potential. What this really measures is the amount of healthy nerve in the nerve that we're stimulating. Well, if we go up higher to the forearm and we stimulate the same nerve, we ought to have the same response. So if the nerve's really healthy here and we get a nice big waveform, the nerve ought to be just as healthy. But lo and behold, what we see is we don't stimulate, or we don't at least observe, as many healthy axons here. The amplitude is reduced. And even if we go higher here, we see it's further reduced and it's also spread out. So what is this? How does this help the neurologist? Well, what this is telling us is that between this point and this point, there is some form of block of conduction, such that not all of the axons are conducting through this nerve segment, so that this waveform is reduced. That's called conduction block, and that is a hallmark of acquired nerve demyelination. We like to see this in patients with CIDP. When we come higher, not only is there ongoing conduction block, but what's happening is this waveform is spread out, and we call that dispersion. And what's going on here is that we're able to stimulate various axons, but they are demyelinated to different degrees so that their speed of conduction varies. And this is a measure of conduction velocity in essence, where these axons out here are traveling much slower than these axons here. And so when we see this kind of pattern of temporal dispersion, it's another indication of an acquired demyelinating nerve problem. So as unpleasant as this test is, and I've had it done to me many times for the purposes of teaching residents and fellows how to do it, it's extremely helpful when we see these abnormalities. But EMGs are not the be-all and end-all. There are problems with making the diagnosis of CIDP using an EMG because we can't always show demyelination. And so one example is there are patients who have a variant of CIDP where they're not weak. Remember, weakness is the hallmark of the typical pattern, but there are variants of CIDP, and one variant is a pure sensory variant. And in that situation, patients are really numb, they have terrible balance, they're very unsteady, they need canes and walkers to walk, but they're not weak. Well, the issue with the EMG is we're looking for nerve demyelination on motor nerve testing. With sensory nerve testing, what happens for complex physiologic reasons, when a sensory nerve is demyelinated, it frequently just drops out, and we can't measure it at all. And so it doesn't help us much. So patients can have pure sensory variants, completely normal motor nerve conductions. We can't demonstrate demyelination. They still can have CIDP, and there are other ways at getting at those cases. There are patients who frequently have axon loss. And this is a function of how bad their CIDP is and how long they've had CIDP. So if you've had it for several years, it's not at all uncommon to develop secondary degeneration of the axons, and that leads to muscle atrophy. But when that happens, axons drop out, and then it becomes harder to demonstrate demyelinating features when you have fewer healthy axons to be able to measure in the first place. And this is very common. So for example, in a patient who has CIDP and really bad foot drop, and they need ankle-foot orthotics to walk, if we bring them to the EMG lab and we try and study their motor nerves in their legs, in their feet, their potentials will be absent. The final common pathway of nerve damage of any cause is axon degeneration. So although the condition could have started as a demyelinating neuropathy, after years, it becomes axon loss. We bring them to the EMG lab. We can't record any motor potentials. It doesn't mean they didn't have CIDP. It means they can't meet the demyelinating criteria. And that's another issue, which is we have diagnostic criteria for CIDP, but that doesn't mean every patient meets the diagnostic criteria, and they just may have too few demyelinating features to satisfy the criteria, and yet they still can have the disease. And this is a situation where spinal fluid analysis and nerve biopsies can provide additional support for the diagnosis. This does not portray well at all. This is a nerve biopsy, and what I wanted to show you, these are the axons coursing through a longitudinal section of nerve, and you can perhaps make out these tiny little red dots. And these dots are scattered throughout the nerve fiber, and they're inflammatory cells. And we like to see inflammatory cells on nerve biopsies. You can see them in other forms of neuropathy, but when you see this in a demyelinating neuropathy, it's extremely helpful to confirm the diagnosis of CIDP. So we have diagnostic criteria for this condition. They exist. They're published. There are many of them. There are a few favored ones that are used for research purposes. And there are clinical criteria, for example, generalized limb weakness, proximal predominance, generalized areflexia, loss of large fiber function, all progressing as a peripheral neuropathy for more than 8 weeks, and other common neuropathies excluded. That's clinical criteria. And then there are EMG criteria. And there's, again, a combination of different demyelinating abnormalities. There's about 16 published EMG criteria out there, so it's rather confusing for the neurologist, but there are some well-accepted good criteria. They exist, and I will tell you they are underutilized. And the problem here is that patients are called CIDP, and they may not have the disease because the physicians are not stringent in applying these criteria, which have been shown to help establish the diagnosis and guide therapy. So lots of people are called CIDP and don't have it. They're important because they tell us if you have the disease, it helps guide treatment options and helps tell us what your prognosis is going to be. I've talked about the clinical criteria and the EMG criteria. When the criteria are not used, this leads to diagnostic and treatment misadventures. I will tell you, I had a patient referred to me in the office about 6 months ago. She was called CIDP. She walked in the office. She had a normal neurologic examination. Her EMG showed no demyelinating criteria. Her spinal fluid protein from many years ago was normal. She had been receiving IVIG for 13 years. And she said to me, I said, I don't even think you have a neuropathy. She said, you mean I've been receiving this expensive treatment and I've been going to this infusion center for every 4 weeks for the last 13 years? And I said, I'm sorry, but that's my opinion. So this happens. So there are a number of issues with making the diagnosis of CIDP on both sides of the ledger. The first issue is the issue of missing cases, missed diagnosis. And this happens all the time. It's probably happened to you here as well. And that is that there are 300 million people in the US. If the prevalence of CIDP is about 9 cases per 100,000, that roughly correlates to about 27,000 people in the United States who should have the disease. And the issue is that we've all seen people, I should say we as physicians have all seen people, where the patients come in and they have a delay in diagnosis. They've had the disease 6 months, 9 months, and they've been slowly getting worse. And the primary care may say, well, you're just getting old. You're just deconditioned, you're not exercising enough, or it's just arthritis, or you've got spinal stenosis or some other problem. Meanwhile, they continue to decline. The GBS-CIDP Foundation actually did a survey, and for the respondents to the survey who answered the question, the average time to diagnosis of CIDP was 13 months. They were symptomatic for 13 months before the disease was made. So the point is we're missing cases, and these are individuals who are clearly not getting proper care. The opposite of this is just as big a problem, or in fact maybe a bigger problem, and this is called misdiagnosis. These are patients called CIDP, they don't have the disease. And there are many examples of this. The big one is mild abnormalities on nerve conduction studies called demyelinating. And again, we have established criteria that are published, what represents an unequivocal demyelinating abnormality and what is a little bit of nerve conduction slowing, and they're not the same. And so I see many patients who are called in the report of their EMG, this EMG is consistent with an axonal and demyelinating polyneuropathy. And you look at the EMG and there's a little nerve conduction slowing in a few nerves. It's simply misinterpreted. The study doesn't show what the conclusion says it shows. Then patients have the wrong phenotype. So I see patients who come in, they say, I have CIDP, I've had some numbness and tingling in my toes for about the last 5 or 6 years. Doesn't bother me, hasn't changed very much. And I tell them, well, you don't meet clinical criteria for CIDP, you don't have it as a first pass. Forget what your EMG shows. And so these individuals who either don't have the right clinical phenotype or don't meet a proper electrodiagnostic criteria, they don't have the disease, and yet they're getting treated for the disease. So they're getting the wrong care. Now, there are mimics to CIDP, and this is what can make it challenging. So there are diabetic patients out there. We know diabetes can cause some nerve demyelination, but you're allowed to have a diabetic distal sensory neuropathy with numbness, tingling, and pain in your feet as a very classic pattern of a diabetic neuropathy and have some demyelinating abnormalities. That does not mean that you have CIDP and diabetic neuropathy. You have a diabetic neuropathy with some subtle demyelinating abnormalities. There are patients who have lots of demyelination on their EMG because they have an inherited neuropathy, an inherited demyelinating neuropathy, and that's called Charcot-Marie-Tooth disease, or CMT. And we see this quite frequently in young people who are called CIDP. They've had a very indolent course of slow progression over many years. They've been stuck on IVIG for years. They're not getting any better, and they're slowly getting worse. And it's because they have a genetic condition. And then there are miscellaneous diseases like lumbar polyradiculopathy from pinched nerves or spinal stenosis or things like this that can mimic symptoms of CIDP with numbness and balance trouble and maybe some weakness and so forth. And this can usually be sorted out by a good history examination and EMG. Unfortunately, at least in the United States, it's now gotten so bad that we see people who are sent to us who don't have any features of a neuropathy and are called CIDP. I kid you not. There's a recent paper that's just been accepted that'll be coming out in the Journal of Neurology in the next few months, where at a referral center, 51 people called CIDP were sent for a second opinion. Of those individuals, half did not have CIDP. And I'll tell you what they did have in just a minute. So part of this is any neuropathy that doesn't meet criteria, they shouldn't be called CIDP. Big problem are poorly performed or misinterpreted EMG studies. And unfortunately, there is a problem of malaligned incentives. There are physicians and communities across the United States who own their own infusion centers, and they're incentivized to give IVIG to patients. People walk in the door, they got numbness and tingling, you've got CIDP, they put it on the diagnostic code, they get into the clinic, they get IVIG forever, and they're not reevaluated, they just keep getting their infusions. We see this all the time on review of cases from insurance companies saying, please tell us what to do in this situation. And invariably, we say there's no data that this individual ever had CIDP, and you shouldn't continue to reimburse for the treatment of IVIG in these folks. So from this paper coming out, 47% of patients called CIDP who were sent to a CIDP expert did not meet criteria for CIDP. What did they have? Some of them had multiple sclerosis. Some of them had Lou Gehrig's disease, which is astounding, how somebody could miss that as a neurologist to distinguish between CIDP and ALS. I have to tell you, I've seen a few cases called CIDP who in fact had Lou Gehrig's disease. Part of having Lou Gehrig's disease is having increased reflexes, abnormally increased reflexes, not absent reflexes. It begs the question, who's examining these patients? Some of these folks didn't even have a neuropathy that you could measure. So some had a small fiber neuropathy, and what that means, patients have burning feet, which is mediated by small nerve fibers. Those folks usually have normal EMGs, not even abnormal EMGs, normal EMGs. And we get to that diagnosis in a variety of different ways. And lastly, about 4 or 5% of these folks had fibromyalgia as their final diagnosis. That's not even a neurologic condition. They had normal neurologic exams and normal EMGs. What's the implication of all of this? Well, many patients are called CIDP and don't have CIDP. And when I give this lecture, frequently there are patients in the room who start to wonder as they hear this, am I in the right support group? You may have CIDP, but you're not getting the proper treatment. And that's an issue of not a proper dosing or treatment response, not a proven protocol that's been shown to help people, and I'll go over this in just a minute. And lastly, you may have CIDP, you have the disease, you're being treated properly, you're doing great, but you're continuing to receive therapy, and you may no longer require treatment. So now transitioning to the treatment of CIDP. There are proven first-line treatments. These are the treatments that should be used first. IVIG is most commonly used because it's easiest, it's really pretty safe, it's generally well tolerated, it doesn't have a lot of side effects, and it works really well in most patients. Corticosteroids work. There are a variety of forms. The old-fashioned treatment, and still used today, and I still use it, is oral daily prednisone in therapeutic doses. That would mean 60 milligrams a day or higher, and I'll go over dosing in a minute. But there are other protocols. There's oral pulse dexamethasone. It's a different kind of steroid. It's given 4 days in a row, monthly, for 6 months, and then stopped. There's IV methylprednisolone, again, given intravenously 4 days in a row, every month for 6 months, in between, not on any treatment. These have been studied in randomized controlled trials and proven to be effective. And then plasma exchange, which is shown to be effective in, I think, the 1985. And it's a short-term effective therapy, but it does work compared to placebo. So anybody here, if you're being treated or initially being treated for CIDP, you should be treated with one of those treatments. They are generally considered equivalent. There have been comparison trials, and the consensus is that IVIG is probably comparable to plasma exchange, and IVIG is probably comparable to at least short-term treatment with corticosteroids. What about unproven therapies? Everything else is an unproven therapy. If you're getting any other treatment, it's not proven to work. It doesn't mean it should not be used in conjunction or in substitution for the other therapies, and I do use these treatments, but I tell folks they're not proven. They help us to manage patients who are having difficulties with the proven therapy. Don't take treatments that are not proven to work as a first-line treatment for CIDP. IVIG. We use it first because it's well tolerated. The biggest problem I see in patients referred to me, it's not used the right way. So we are assuming the patient has the disease. They fulfill clinical and electrodiagnostic criteria for CIDP, and they get better with IVIG, but they're coming to see me with a walker or a wheelchair. What's going on? There's a way to do the treatment. It's a proven protocol. 2 gram per kilogram loading dose, 1 gram per kilogram every 3 weeks for 3 to 6 months. That's the biggest study that was ever done. It's not the only protocol, but it's a good one. It works. I see people who come in and they never get a loading dose. They get half the maintenance dose every 6 weeks. So they get a little bit better for a few weeks, and then they crash and burn, and then they get a little bit better for a few weeks, and then they get worse again, and they do this roller coaster ride, and they don't understand what's going on. And my response is, why don't we do it the right way? So we load you with IVIG, 1 gram per kilogram per day for 2 to 5 days, so 2 grams total, and then 1 gram every 3 weeks. And we do this until you get all better, or you reach a plateau, or you don't respond. And then we move on to a different proven treatment protocol. There's another approach, 2 gram per kilogram divided over 4 days. That's IV. You can do it that way. That also works. And you do it monthly for 6 months. Again, another option. Once the clinical response has been achieved, you stop treatment and you observe. You should not be stuck on IVIG the rest of your life. If you relapse, okay, you're dependent on IVIG. That's fine. We restart the IVIG and then we individualize the treatment. We try and figure out what's the least amount you need and what interval do you need it to keep you as normal as possible. The biggest reason for IVIG failure is improper dosing, too low, or improper interval treatment, too long between treatments. Some of the side effects, a lot of folks will feel tired, not sort of an ill feeling, malaise for a day or so afterwards. It's a lot of fluid, and so we have to be careful in people who have fluid medical problems like congestive heart failure or kidney issues where they can't mobilize the fluid well. We often tell folks, make sure you empty your bladder after you leave clinic because you don't want to stop on the middle of the road if you're driving a long way to pee. A lot of folks get headache. That's the most common side effect. It's usually not serious. It can be managed either by slowing the rate of the infusion, or you can pre-medicate patients with a small dose of corticosteroid, IV, or use standard medicines that we use to treat migraine headaches, such as any of the triptan therapies. And all this can be very effective. You want to be able to give the patient the drug they need, but be able to manage the annoying side effects if it's a problem for them. Some folks get rash. And this is particularly an issue if you've had psoriasis. You can have a fulminant explosion of psoriasis if you get IVIG, and so it's a relative contraindication. There are rare but serious side effects. So patients who have kidney dysfunction, you need to think twice about IVIG because it can aggravate kidney failure, or it can put people into kidney failure who have borderline kidney function. In folks who have abnormal thickness of the blood called hyperviscosity, that can cause problems, particularly if you have artery disease, atherosclerosis. It can aggravate peripheral vascular disease, coronary artery disease, cerebral vascular disease. So you have to be just aware of that and use IVIG cautiously in those patients. When do you stop IVIG? Well, when there's unequivocal improvement and the patient's been stable over multiple infusions, where there's no cycling between treatments. That's the key, that they're not still getting symptomatic in advance of their next infusion. If you stop the treatment, they're going to get worse. So you need to keep them on the treatment then. You can stop it, or I should say most patients will see some signal of benefit after the 3rd cycle. So that means they've had 6 weeks of treatment. So baseline, 3 week, 6 week, when you see them back at 9 weeks, you'll have an idea. And the vast majority of patients, they're either starting to get better or they're not. And if they're continuing to decline, you don't need to keep giving them IVIG. It suggests that IVIG is not working for this individual, and you need to move on to another proven therapy. So if there's clear progression or no response to an adequate trial, don't keep up with a treatment that's ineffective. So how do you go about actually getting people off IVIG? The answer is nobody really knows. In the trials that were done, there are a number of options you see here. Option 3 is what was done in the trials, which is you just stop after a pre-specified time of treatment. That's usually 6 months. So in the large trial called the ICE trial, people received IVIG every 3 weeks for a 6-month period of time, and then they stopped. And for the next 6 months, 45% of patients stayed in remission. They stayed good. They didn't need to be treated. The others relapsed and went back on IVIG treatment. So there are a few approaches. One is lengthen the interval between infusions. So after you're stable for a period of time, every 3 weeks, you can go to every 4 weeks. If you're doing well there, then every 5 weeks. If you're doing well after that cycle, every 6. And by the time you get to 6 to 8 weeks off IVIG, you're probably off IVIG because the half-life of the drug is only 3 weeks. So it's out of your system, and if you're still doing really well at 8 weeks, it means you're probably in remission off IVIG. That's in fact what I do, is I slowly lengthen the interval to see how people do, and if they stay in remission, we can just stop the drug after several cycles. Option 2 is to reduce the dose but keep the 3-week interval. So if you weigh 80 kilograms, you're getting 80 grams of IVIG every 3 weeks. If you're really stable for a long period of time and you're doing well, maybe you can cut it down to, say, 70 grams. And if you do well with that, the next cycle, 60 grams. And just walk your way down so that by the time every 3 weeks you're getting 10 or 20 grams of IVIG and you're not changing at all, you're really stable, you could probably stop the drug. The key is to follow these patients, to watch them, to make sure they're not getting into trouble. You don't want them to relapse and get bad all over again, but you'll have a clue if somebody is not doing well as you're coming down on IVIG, that they're dependent on IVIG, then you need to go back up to the therapeutic dose that worked. What about corticosteroids? Again, multiple protocols available. The key to success in using corticosteroids is to use the proper dose for the proper duration and objectively measure change from pre-treatment baseline to treatment over a fixed interval. The biggest problem that I see in patients who use steroids, again, is that they're not using it properly. I see folks where the dose is too low. They've been on prednisone 20 milligrams daily for 6 months. They're not any better. That's not surprising. That's a really subtherapeutic dose. We target at least 60 milligrams per kilogram, 1 gram per kilogram per day for prednisone. So that's roughly 60 milligrams daily, sometimes more. Sometimes it's as high as 80 or 100 milligrams daily. And you got to do this for at least 2 or 3 months to make an assessment. Now, you may see benefit in 4 to 6 weeks. That's terrific, but you can't just stop the steroids then. The patient's likely to relapse. So there's a way to get off the steroids. The other problem is you use the right dose, you just don't use it long enough. So I've seen patients start a Medrol dose pack, truly. They have CIDP, and they start 60 milligrams per day, 50, 40, 30, 20, 10 off. And they feel great for a couple of days, they feel good, they're not any better, and then it doesn't work. And I've seen people, take 60 milligrams for a couple of weeks, then 50 for a couple of weeks, then 40, and they're off it in 6 weeks or 8 weeks. And they were starting to get better, they kind of leveled off, and then they got worse again as the dose came down. The big problem with steroids is side effects, and that's particularly true with exposure to chronic daily oral prednisone. Here's just a brief list. The real list is probably 3 or 4 times as long as this. So not everybody gets every side effect. I've had folks who have no side effects from prednisone, and I've had patients who have 10 side effects from prednisone. They simply can't tolerate the drug. So some of the short-term side effects are weight gain because it increases appetite, puffiness of the face, Cushingoid facies. It can aggravate hypertension. It can trigger or aggravate diabetes in diabetic patients. It can upset the stomach. It can interfere with sleep. It has a lot of mood issues, can make people very irritable and short-tempered. In some individuals, it can make them delusional and psychotic. Tremor is very common, easy bruising. The long-term side effects are harder to reverse. So osteoporosis is a really big deal, and if you're on chronic prednisone, you need to be monitored by your primary or some physician with a DEXA scan to see what your bone density is on a regular basis, and if necessary, you need to treat osteoporosis. Some folks get a syndrome called aseptic necrosis of the hip, which is basically a bone-hip fracture, and you can't fix it once it happens. You may need a hip replacement. Stomach upset can be so bad that you can get gastrointestinal bleeding, which can be a really big deal, and people need to be hospitalized and need blood transfusions and so forth. Prednisone works by suppressing your immune response. That's the desired effect, but it also predisposes you to infection. And so folks can get weird infections with chronic prednisone therapy that can be very serious, and glaucoma and cataracts, and the list is much longer than that. So let's say you do great with steroids. Oral daily prednisone as the prototypical example. How does one get off it? Well, this is one approach. There are multiple different approaches. There is no best way to taper prednisone. The wrong way is to stop it, not like IVIG, where you can, in theory, just stop and watch. Patients can withdraw. They can suppress their adrenal gland function if they've been on reasonable doses of prednisone for too long and go into what's called Addisonian crisis. It's very serious. You can't just stop high-dose prednisone. So you do a tapering schedule, and you can cut the dose down by 5 milligrams a month or 10 milligrams a month if the patient's doing well. The next month, another 5 or 10 milligrams, and slowly walk patients down until they come off the drug. The lower your dose, as you get closer to 20 or 15 milligrams, the smaller the change. You may need to drop the dose by, say, 2.5 milligrams monthly to be safe about it. Alternatively, you can do what's called an alternate day taper, where patients can be on 60 milligrams one day, 50 the next, do that for a month, 60 and 40, alternate that for a month, 60 and 30, and walk your way down that way. There's no ideal best way. What you don't want is what I call the worst case scenario, which is patients have lots of side effects from prednisone. For example, 50-pound weight gain. And because of that, you taper their prednisone quickly. And their disease is doing well. They're in remission, but they've got gastritis, they can't sleep, they're unhappy. So you taper too quickly, and then the disease comes back. So now they're in the worst scenario because the side effects don't go away quickly. You're not going to lose 50 pounds in weight in 2 weeks. So now they've got all the side effects and the osteoporosis and everything else, and yet the CIDP is back again. So you got to be really careful about tapering that. For the studies in pulse dexamethasone, we have our star pulse patient there. You just stop it, and generally that's at 6 months. And same with IV methylprednisolone. If you use those proven protocols, you do it for 6 months and then you stop and you observe. If the patient does well, you keep them off treatment. If they start to relapse, you reinitiate the therapy. Plasma exchange, likely as effective as IVIG and corticosteroids. The problem is it's really a short-term treatment. It doesn't last very long. The concept is that you're theoretically removing the pathogenic antibodies against your peripheral nerve myelin, such that the exchange withdraws it. Think of it as a dialysis type phenomenon, filtering it out, which allows your nerves to remyelinate, and that can happen fairly quickly. So we use exchange in the setting of people with very severe or quick relapses where we want to get them better because they're so bad they can't take care of themselves and they're in a hospital. So it's classically used in the inpatient scenario, although it can be used in an outpatient scenario, particularly in patients who have good veins. The big issue with plasma exchange is the need for venous access because the needles are really large, so you need big veins. The problem is if you're not young with healthy veins, it requires a central catheter to be placed, usually by a surgeon, and then we can exchange you that way. The problem there is that the catheter can get infected, the catheter can clog, and it has all sorts of side effect issues. So classically, we'll use exchange for several weeks, taper the frequency, maybe 1 to 2 exchanges a week for a month, and then weekly for a month thereafter. It's very hard to maintain plasma exchange as a long-term therapy. There are patients who have permanent catheters placed, and they can come in and get their exchanges, and I've had a few people in my practice who only respond to plasma exchange, and so that's what we have to do, but it's not without its problems. So we do all of this, and the patient gets better, and that's terrific. That's what we want. But what does getting better really mean? I will tell you, if you give prednisone to any of you in this room, you will feel terrific. It has a wonderful boosting energy phenomenon. That doesn't mean your foot drop gets better. So lots of folks feel good on these treatments. They feel good getting a lot of attention and aggressive treatment from their physicians and their physical and occupational therapists and so forth. That doesn't mean that the treatment is working on the disease. So feeling good is great, but really doesn't count. What we need are clear and objective measures of a clinical response. And that means metrics. Improved bedside strength, like how we would test your muscles before, and we would say you're weak in these muscles, and now you're strong in these muscles, and we can measure that change. We can count how many seconds you can stand with your eyes closed. You couldn't do it before, now you can do it 10 seconds. That's a metric of improvement. We can time how long you can walk down a hallway a fixed distance, before you got treated and after. These are some examples. And we like grip strength. Everybody who comes into my office grabs the handy-dandy grip meter, and we get a quantitative measure in kilograms of how strong your grip is. It's a fabulous metric to measure change, at least in that muscle group. But really what's important to the patient is functional disability. That's what counts most. And physicians do this in the office all the time. Tell me what you can do now with IVIG or corticosteroids that you couldn't do before treatment. Oh, doc, it's great. You know, I can go up and down stairs, I can go shopping, all of these things. And this is what we used to do and still do informally in the office to tell us our treatments are working. But it's much better if we can formalize it. And this slide does not project well, but what I can tell you is that there are now formal metrics of functional disability. There are scales that have been validated in Guillain-Barré and CIDP looking at change and improvement in an orderly fashion, from the easiest thing to do, such as reading a newspaper, to the hardest thing to do, which is running. And so what we're looking at are two things. We're looking at the patient's level of disability at their disease level, and we're looking at increasing tasks of activities of daily living. And we're pushing them together. And then we're using very fancy statistics called Rasch analysis, which tell us that the change from one point to another on the low end of the scale is similar to the change of 1 point on the high end of the scale. And therefore, we can quantitate change. And this is called the Rasch-build Overall Disability Scale, or RODS. And again, unfortunately, due to the lighting, this doesn't project well. But really what it asks are a series of activities. Can you use utensils well? Can you button buttons? Can you hold a newspaper? Easy things for the hands. Can you walk independently 10 meters? Are you able to shop? Can you take public transportation? Can you go up and down stairs? Can you catch a ball? Can you run? All of these things. And the answers are 0, no, I can't do that at all for each of these tasks. 1, I can do it, but with difficulty. 2, easy to do, no problem. You add it up, you get a number. That number transfers to a nomogram that's been established, and we can actually quantitate your level of functional disability at the time you fill this out. This has been shown to be as effective as any of the other endpoints that we use in measuring change in treatment with CIDP, and in fact, it's now been adopted in virtually every clinical trial moving forward for CIDP, looking at new agents to treat the condition. How do we assess change? Does the patient need treatment? So there's a bunch of things also just to think about. Not everybody with CIDP needs to be treated. There are patients who do have mild disease, and it's stable, and it doesn't interfere with their quality of life and their day-to-day activities. That just because you have the disease doesn't mean you need to be treated for it. The treatments are a hassle, they have side effects, as you've heard, they can be very expensive. Not all do. You need to measure the metrics at baseline before you initiate a therapy, begin treatment, do it the right way for long enough to conclude it either worked or it failed. And then you need to reassess with these objective metrics frequently. It's not good enough, what I see, it's not good enough to give somebody IVIG and say, I'll see you in 9 months. Or come to my clinic, get your infusion, and we have an evaluation from the physician, and then there are no evaluations for a year and a half while the patient keeps getting IVIG. When do you change treatment? There's a couple of basic rules. When you're not getting better, you shouldn't stay on the same treatment if you've done it the right way for long enough and you're not seeing improvement in these objective metrics, which of course translate to functional abilities. When you see this, always reconsider the diagnosis. If you're improving, but it's really not that much. So the treatment does seem to help, but you're still badly disabled. That's a reasonable indication to switch to another treatment, which may be more effective. Or if you have side effects from the treatment you're getting. There are patients who get IVIG, they have blistering headaches, disabling headaches that require hospitalization. In rare cases, it can cause inflammation of the lining of the brain, called aseptic meningitis, where they're so sick and so ill and hospitalized needing to get treated for their headache that they can't take IVIG. That's a reason not to continue the treatment. What about all these second-line therapies that you may have heard about or are taking? There are many. As I've said, none of them are proven to work. The best indication to use these agents is to keep the patient stable in somebody who's responded to the proven therapies, and then allow them to wean the proven therapies so that these folks are not stuck getting IVIG every 3 or 4 weeks the rest of their lives. If we can get them stable, use one of these second-line drugs that are oral drugs that are well tolerated, hopefully without side effects, there's a chance they can come off IVIG. And the same is true with steroids. In fact, most of the treatments I'm going to talk about were designed as steroid-sparing drugs in patients who improved with steroids, but we know we don't want to keep these folks on steroids forever because of the side effect profile. Some of these medicines will keep the patient stable and allow successful tapering of the corticosteroid. When to introduce alternative, no improvement, right? So we've sort of talked about that. The other issue is, in patients who do respond to the proven treatments, but they relapse a lot, so their disease just isn't under good control, that's another good reason to try and offer some of these immune therapies, recognizing they may not be effective, but the current clinical situation is unacceptable to the patient or the physician. When you have patients who are not improving at all with any of the proven treatments, they have received IVIG properly or multiple different steroid regimens or plasma exchange, and nothing has worked, the first thing to do is to reconsider the diagnosis. Are you treating the disease? In a large trial that was done with oral pulse dexamethasone, it was shown in retrospect that 18% of people who were entered that trial did not have CIDP. They met the criteria for CIDP. It turned out later they didn't have it. A few had an inherited neuropathy, a few had malignancies, there were a variety of other causes. So always to keep in mind that if you're not improving with any of the proven therapies, you need to wonder, is the diagnosis correct? So here are a few of the second-line treatments you may have been taking or may have heard about. Azathioprine is the oldest. It's been around for probably 50 years. It's a classic steroid-sparing drug. It's used in a variety of other autoimmune diseases by rheumatologists, and it can be very effective in getting people off steroids. Its cousin, a drug that came out probably about 10 years ago, maybe even longer, is mycophenolate mofetil. Works in a similar fashion to azathioprine, generally a little bit better tolerated. There are other treatments, methotrexate, cyclosporin, rituximab, and even chemotherapy, cyclophosphamide, in really treatment refractory cases or in patients who simply can't get off the treatments because they relapse every time. Some of these drugs have never been studied in a meaningful way. Methotrexate was studied in a randomized trial and was shown that it didn't help people get off IVIG or corticosteroids. The problem was, in retrospect, that there were many difficulties in the design of that trial, such that the lead author of the paper said that we can't conclude that methotrexate does not work in CIDP. So it's on the table as something to use. Interferons, same story. There's a few drugs. Interferon beta 1A was studied. It's an MS drug, and that turned out to be a negative trial, but there were, again, design problems there. The take-home message is that if you're on these agents or contemplating using these agents, you want your treating doctor to be comfortable with using these drugs and how to manage them and their side effects. And if they're not comfortable using them, they shouldn't be using them. So in concluding about the diagnosis of CIDP, make the diagnosis. Be as certain as you can. Use the widely available diagnostic criteria and apply them. And for physicians, it should be done in a systematic fashion. History exam, blood test, and EMG are usually sufficient to make the diagnosis and exclude other mimic neuropathies. I advise patients you need one really good EMG, not 10 bad EMGs. And I frequently see this and unfortunately say, I can't do much with the EMGs you've had. You had 2 nerves studied. You need like 5 or 6 nerves studied. You want to use proven treatment protocols proven treatments in the right way, using the protocols that have been published. If you don't respond, reconsider the diagnosis. Once you're better, you don't live on the treatments forever. You get off the treatment and then you observe. If things don't seem right, and this is very hard for patients to know, and what I advise is use your sensibility, your gestalt, your gut feeling. If something doesn't make sense to you, if you don't feel good about how things were explained to you or you're confused, get another opinion. It's just helpful just to know, to be comfortable that you're on the right track, because otherwise, if the diagnosis is wrong, you're going to be exposed to potentially toxic medications for a long period of time without any compelling reason or any expectation that you're going to improve. GBS-CIDP Foundation has designated centers of excellence around the country. If you can't find one of those, any major medical center that's a tertiary referral center with a large neurology department will have at least one capable neuromuscular specialist who will be familiar with CIDP. When should you consider this? If you don't have the clinical features of CIDP I've talked about, that's a good clue. If your diagnostic tests point to another condition, you shouldn't be getting treated for CIDP and maybe get another opinion, particularly if your diagnosis was made mostly based on your electrical studies, not the clinical features. If you're not improving with the treatments you're supposed to improve from, or if you've been stable for a very long time and you want to come off treatment but your doctor's afraid to. These are reasons to think about another opinion. And that's my last slide, and I think I'll stop there. Thanks for your attention. I think we can open it up, and I'm happy to entertain any questions anybody has. I think what we'll do is we'll pass the microphone around.
I've been diagnosed with Guillain-Barré syndrome, but everything I've seen here, I seem to think I have CIPD. I mean, are they the same thing? Or?
No, they're different diseases. So Guillain-Barré is a one-time disease. Once.
Yeah.
You get bad fast. The clinical features and the EMG features and the spinal fluid features look identical, but then you get bad and then you reach a bottom point called a nadir, and then you get better, with or without treatment, which is IVIG or plasma exchange, not corticosteroids, and then you get better and you stay better. Now, better doesn't mean normal. You may have leftover symptoms, numbness, tingling, pain, weakness, fatigue. All of those things are all leftover symptoms of GBS. But what you should not be seeing is I'm better and then I get worse again. I get weak again. My numbness comes back. My balance was great and now it's not good in a chronic pattern for more than 8 weeks. Guillain-Barré is maxed out generally at 4 weeks, and then recovery over the course of the year, and then you are stable, 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 stable. You may have subtle fluctuation in numbness and tingling and pain. Those are symptoms that can fluctuate, but fundamentally, GBS doesn't come back the way CIDP will relapse off treatment or continue to progress without ongoing treatment. Does that make sense?
Yeah, it does. I've had it for like about 4 years now.
You had GBS 4 years ago.
Well, 4 years ago, Guillain-Barré syndrome. And
Yes.
then, I was in hospital 7 months.
Yes.
I progressively have been getting better. I was in a wheelchair, then a couple of canes. Now I'm walking with a cane.
Yeah, see,
After 4
terrific,
years, and so I
long
have been
recovery.
steadily getting better, but
That's
it's been
GBS.
a long process.
Right, but it hasn't been where I got better, where I'm on a cane, and now all of a sudden I need a walker over the neck. See, that's the distinction.
Okay. All right, great. Thanks.
Okay.
Doctor, quick question, hitchhiking on that. I had GBS 17 years ago, and as I get older, I noticed that I once could wear heels after I kind of recovered, but had the residual of weak legs. But I can't wear heels anymore after 17 years of my agility and weakness. It seems like it's becoming more impaired. Is that old age, or is that
Extremely
something else?
common story, not CIDP. What's going on as we age, there's a natural decline in high-level function, so that your energy capacity may not be as good, you might fatigue easier, your balance may not be as good, and so if you had some leftover weakness as a function of GBS 17 years ago, but were able to get by in heels, probably with some effort, you're just finding at a point now that you've decompensated. It's not that you're weaker or that the disease has come back, unless there are other features that you didn't have before that are also getting worse. So my suspicion is it's a combination of age-related change, which is very slow and imperceptible, where people start to notice, gee, I'm having trouble doing stuff as well now as I could 15 years ago.
Mm-hmm. And then one other quick in regard to chronic fatigue, is that, again, that's part of aging as well as having limited strength.
Yeah, so one of my colleague neuromuscular folks said everybody over 40 is tired.
Oh boy.
So, but with that, with that, so fatigue is a natural part of life, particularly if you're stressed and sleep deprived and don't take care of yourself, so on and so forth. But fatigue is an extremely common symptom that's left over from GBS. It's hard to treat. We don't really understand the mechanism of it, but absolutely you can have that, and that can fluctuate. So that's a leftover residual symptom, and it can fluctuate, but it's not the same as I can't climb stairs now because my legs are weak, and I could climb them 2 months ago because they were strong. There's a difference between fatigue and weak.
What's actually going on when you get a good result, let's say a treatment, and all of a sudden you feel better? What is happening? Is the melon getting covered over and you can...
Right, so there's a variety of mechanisms we think are happening. So there are some people who get dramatically better, usually with IVIG, like within days. I mean, it's really amazing. That's rare. Maybe 10 or 15% of patients will get better that quickly. In that situation, what we think is happening is that your antibody is binding to myelin and blocking it, but not destroying it. And so it gets unblocked quickly. and suddenly nerve conduction gets better and you get stronger. What more often happens is through complex mechanisms with IVIG, corticosteroids, or plasma exchange, your immune system is being altered. The treatments for this are immune-oriented, not nerve-oriented. But what happens is if we can modulate your immune response to tone it down or change it in such a way that the myelin can heal on its own, the natural tendency is for myelin to remyelinate if it's been demyelinated. And that usually takes on the order of weeks or months, which is why we have to give people enough time on the treatment to see that they're going to remyelinate.
That was my second question was, the IVIG is supposed to boost your immune system, but you say the steroids suppresses it, so that kind of gets...
Right, so the treatments work in different methods. So IVIG, think of it as good antibody from blood donors from thousands and thousands of people. It probably has 10 or more mechanisms of action. We don't know which mechanism is most relevant, and maybe there are multiple mechanisms that are most relevant in CIDP. So we really don't know for certain how it works. It's very hard to study that. So in that situation, it may neutralize the bad antibody, it may reduce inflammatory chemicals that are circulating around the nerve that are causing demyelination. It may block certain chemicals to bind to the nerve. So there's a variety of ways. With corticosteroids, our understanding is basically it's suppressing the production of inflammation in your body that then turns into nerve fiber demyelination or inflammation. So the mechanisms, some are overlap mechanisms, but clearly there's different mechanisms.
All right, I was diagnosed about 7 or 8 years ago with peripheral demyelination, and it was attributed to an IgM MGUS condition, and initially treated with rituximab, and then after that plateaued, then the IVIG. Now it's been 5 years since I've had any kind of treatment at all, and it has been very, very slowly recurring over that time. And what I'm wondering is, back then my next option was going to be chemotherapy, and I chose not to do it because it wasn't that severe. Have the options for the MGUS treatment been modified at all over the last several years?
A great question. So just for the audience, so there are a variety of different inflammatory demyelinating neuropathies, and I've talked about CIDP as the classic chronic one and Guillain-Barré as the classic acute one, but there are folks who make a specific antibody that we can measure in their blood called a monoclonal protein. And in those individuals, some of them make an antibody called anti-MAG, or myelin-associated glycoprotein. Their clinical syndrome is very different. They have a very indolent, very slowly progressive problem over many years, and it's mostly a sensory neuropathy. It's numbness, it's tingling, it's balance trouble. The party line, in my view, is that in general, we don't treat these patients because there's no proven therapy that works. So that's the purest approach. And I see lots of folks just like you. And if you have a normal or near normal exam and you have no meaningful functional disability, I recommend just following you to see that you stay that way. There is a threshold upon which patients get disabled from the condition or they're approaching disability. And that for me is balance. If you start to notice unsteadiness and your risk of falling increases, then I inform patients we have treatments. They're not very effective, and when they've been submitted to rigorous studies, most of them don't work. But sometimes they work in some patients. And that would be IVIG first, actually, where there was one study done many years ago in a small number of patients where a small number seemed to improve. Because IVIG is pretty well tolerated, I usually start with that, and I treat for 3 to 6 months, and then I stop and see what happens. And then this other drug, rituximab, which has come online as a favorite drug to use with your kind of neuropathy if you have an IgM protein and anti-MAG, anti-MAG antibodies. Lots of anecdotal case reports suggest it helps people. There was one study published now about 3 years ago that looked at 50 plus patients with your syndrome with rituximab and showed that it wasn't any better than placebo in the endpoints that were chosen. However, one of the criticisms of that study was that they may have picked the wrong endpoints. So they found in that study that 20% of people who got rituximab had measurable improvement in balance compared to none in the placebo group. So my own view is not to treat you as long as you're managing with a good quality of life and your fall risk is 0. If you are drifting in the wrong direction, it is worth the conversation as to whether retreatment should be instituted. If so, which treatment and for how long. Nobody knows which treatment to do first, and nobody knows how long you treat. So it's variable. And I've had patients also before rituximab came online that I have treated with Cytoxan, cyclophosphamide, a chemotherapeutic agent, serious drug, a lot of potential side effects, needs close monitoring, but these folks were so bad that they were wheelchair bound from their condition. And it was live this way or I will assume the risk. You've been informed, you understand the risk-benefit analysis, let's try it. And in some of those patients, they did get much better. So there's things to do, but I hope one of my favorite phrases is not to confuse activity with progress.
So I have several questions, actually. I was diagnosed with CIDP around 6 years ago, and I'm on IVIG, and we've tried different lengths of time between treatment and so on. But my question is, and we kind of moved up to like 6 weeks and then back to 5 weeks just because I did notice a difference. But my question is, if you do relapse, have you seen that it's more difficult to get someone back to the position they were in before, or is that easily done?
It should be easily done. It should never be in a situation where you ever get as bad as you were before you ever started IVIG. And this is why the concept of going 4 week to 5 week to 6 week is a good one, because you're not likely going to fall apart with a 1 week difference. But if you're saying, I'm starting to see noticeable decline because I'm familiar with my disease, and so I know what's going on, such that you can't make it to 6 weeks and be pretty good, and that you need it at 5 weeks, that tells me, one, you're dependent on IVIG, that you need your IVIG. Two, you need your IVIG at a minimum of every 5 weeks. You might want to, if you're still not great at 5 weeks, you could kick it back to 4 weeks where you're actually way better, and that's a discussion to have. At that point, you have some choices to make. You can decide, I'm going to live on IVIG forever, periodically reassessing, but I say forever because you're dependent on it. So if you don't get it at 4 or 5 weeks now, there's no reason to believe a year from now you're not going to be in the same situation because you've done the experiment. Every once in a while, what I do is if people who are really, really stable at 4 weeks, and I try to get them off before, we'll keep them stable for 6 months and try it again. After a couple of trials, you don't need to keep reinventing the wheel. It's clear that if you're going to prove that you're dependent on IVIG, you're dependent on IVIG. You can then continue to get the treatment at the dose and the interval that suits you to keep you at your best. That's called individualizing the treatment. And that's all you need to do. Some people have the perspective, I really want to get unhooked from this IV. So what else do you have? And that's a situation where if you and your doctor agree, you can try these other unproven treatments with the goal of getting you off IVIG but keeping you stable.
Okay, makes sense. Also a question, I know this came up with respect to Guillain-Barré. With respect to fatigue, you didn't mention that at all when it comes to CIDP, but I know I've read somewhere that often people that have CIDP do experience a lot of fatigue. Is that your experience?
Yes,
or not?
absolutely.
It
so
is? Okay.
fatigue and pain can be issues independent of the functional disability of the neuropathy. So that's noticed as not on that RODS scale that we use because we need more objective metrics. It's not to say that you don't have disabling fatigue and or pain, but that's not a reason to continue corticosteroids or IVIG or plasma exchange or any other treatment. If you're otherwise neurologically intact and you can do everything you need to do, we can try and treat fatigue symptomatically. So simple things like building in rest periods during the day, making sure you get adequate restorative sleep on a regular basis, making sure you keep well hydrated, that you eat nutritiously, that you have a moderate, regular exercise regimen. Those are the things that patients can do, and that'll often make a big difference. Then there are pills. And we got lots of medicines to try and address fatigue. None of them have been proven to work. Most of them are of modest benefit. So every once in a while, you find a drug that is a home run for a patient. They're like lives are changed in terms of fatigue, and the same is true for pain management. We don't use IVIG to treat neuropathic pain in CIDP. We use other medicines to treat the pain.
So I really shouldn't be concerned then if I can sleep 11 or 12 hours straight, which I can and do often.
If that's what you need to function well, yeah. So the other side of this is it's not a reason to give you IVIG so you sleep only 7 hours. Okay. That's the way to think about it.
Understood. Then one final question, and this one may be more for the group. I'm about to get on Medicare in December, and don't have much, if any, information as to where you go and how the medicine is billed. Does that come under the supplemental plans or primary plans and so on? I don't know if anybody else has any experience with being on Medicare and so on.
So in reference to prescription coverage or?
Well, I get the intravenous, the IVIG. So sometimes from what I've heard, you have to have, I think, supplemental through Plan D, depending upon where it's administered even.
That's correct. So I can actually answer this for you from my own experience. So I treat a lot of Medicare patients, and what will happen is you need to have a supplemental plan, and if you get IVIG in an infusion center, like a facility, like a hospital, then your secondary will pick up the cost of that.
Who decides where you get the treatment? Because my insurance company they've been pushing back and forth.
Oh, I can tell you, if you have Blue Cross effective July 1st.
I don't.
If anybody has Blue Cross effective July 1st, you have to get it at home infusion.
I started with GBS 2 years ago. About 3 months later, I got promoted to CIDP. IVIG every 6 weeks now. Just a question about, my neurologist used the term burning out, because I was thinking chronic means like this is forever, which was kind of shitty news. But he says it's not really forever. I mean, it burns out after a while. What does that mean? I mean,
that's exactly correct. And so for many years, up until probably the last decade, people and physicians were under the impression chronic meant this is a lifelong disease. So that's simply incorrect, okay? So depending on where you are in your disease process, if you're real early and you can get treated aggressively and get to a normal neurologic exam, we know anywhere from 40 to 50 to 60% of patients can come off treatment after 6 months and remain in remission. Now, remission can be normal if your exam is normal, or if you have very severe deficits from long-term disease where you have axon loss, the axons may not regenerate. So if you have a foot drop, we can give you all the IVIG in the world, everything else is great, but your foot drop may never get better. That's at what we call a fixed deficit. So in that situation, you're not normal, but you don't have active disease. Can you see the difference? And that's where I think the term burnout comes from, which is you're off treatment, you're not active, you're not relapsing in terms of getting new neurological disability, you have a chronic, stable, fixed disability. That's probably going to be lifelong, but that doesn't mean your CIDP is still active. So we did a study years ago that looked at, I think, 105 validated cases of CIDP where there was a consensus that 10 of 12 CIDP experts looked at the records of all these patients and confirmed, we all believe this is a case of CIDP. And then we looked at what their treatments were and where they were at last follow-up, and we had an average follow-up of about 5 years. So what we found was that, and some people had longer, but what we found is about 20% of people were technically cured in the sense that they had been off all treatment for 5 years and were stable. Now, they weren't always normal. Some were normal, and some had fixed deficits. But 5 years out on no treatment would suggest their disease is burned out. It's not active. Now, is it possible they could relapse after that? Yes, because this wasn't prospective and we didn't follow them 10 years. But that's the best available evidence that we have right now. About 30% of patients are going to be stable on treatment. And what that means is they're doing well with IVIG. It's actually 50% of people are on active treatment. So that means they're doing well, they're responding, but they need to be treated. Their disease is active. If you stop their treatment, they're going to relapse again. Then there was a group in between, and that was about 30%. And these were people who had been on oral immune drugs, and they had been stable for 5 years, but they were still on the treatment. So in theory, if they could stop the treatment and remain stable off drug, they'd kick up to the better category. And really, this was a function of follow-up. It's like, how long did you follow the patient in the records? And what treatments were they on for how long? And what did their exam look like at the time of the last follow-up? Those were the parameters. But the concept of burned out CIDP is true. But I think people will confuse burned out with normal. And that's not the same. If we can catch you early and treat you aggressively where it's just a myelin problem and not a lot of axon loss, and we can get you normal and keep you normal, you might be normal burned out, and years later on no treatment and normal and the disease is gone. And we sort of liken it to cancer, but 5 years out, if you don't have anything, you're free. But that paradigm's not perfect because cancer's different, right? I mean, this is an immunologic disease, not a malignancy. So if you're 5 years out from your lung cancer off treatment without any evidence of cancer, you'd be considered cured. We sort of borrow that concept to apply it to CIDP, but it's not a perfect match.
Because you've got a new normal.
Well, it's that, plus you're talking about a chronic immune disease. And so who's to say that the disease isn't going to come back at year 6 or 7, right? I mean, it's different. If you don't have cancer, if you don't have your primary first cancer of the lung at 5 years, and it's gone at 5 years, it doesn't mean you're not going to get some other cancer. It just means that cancer's gone.
Do you know of any information or evidence about a correlation between vaccines and the demyelinating neuropathy?
Okay, so very hot and popular topic. So first and foremost, with CIDP, the short answer is no. Okay, there's no credible evidence that any vaccination of any kind is going to cause CIDP. And it's hard to study because it's a chronic disease and you have to have huge populations of people who are vaccinated and not vaccinated with a single type vaccine for one particular disorder. It's very hard to study. And in retrospect, there was a suggestion in one study that maybe tetanus that was given to people who had CIDP increased their risk of relapse slightly. It is not great science, and if you need a tetanus shot, you should get a tetanus shot, whether you have CIDP or not. So CIDP's no credible evidence to tell you not to get vaccinated. With Guillain-Barré, it's basically the same story, which is that if you've never had Guillain-Barré before, you should get a vaccine for the flu, and for that matter, any other vaccine, if it's indicated because your physician says you have an appropriate reason to get the vaccine. We know that if you vaccinate millions and millions of people, there is a relationship between the flu vaccine and GBS, such that for every 1 million people who get vaccinated for the flu, there is one extra case of GBS beyond what would have occurred in the general population. If you are that one that gets GBS-related flu vaccines, you get vaccinated and within 6 weeks you get Guillain-Barré, it's a general recommendation you should not get the flu vaccine again. Doesn't speak to any other vaccines. Here's what's really interesting, and this data just came out in the last year or so. We know that there's this slight excess risk if you get a vaccine of getting Guillain-Barré. We know that Guillain-Barré is triggered by viruses. It's like a known association. So that if you get the flu, the odds of getting Guillain-Barré from influenza infection are about 15 times greater than getting it from a vaccine. So in fact, the vaccine, relative to the risk of flu-triggered Guillain-Barré in the general population, is protective for getting Guillain-Barré. So in turn, people who have an indication should get vaccinated for the flu vaccine. It kills about 35,000 people a year. We know the meningococcal vaccine, Menacta. Yeah, as far as we know, there's no risk. Any of the data that have been looked at, there's no excess cases of GBS within 6 weeks of exposure to that vaccine. And there was a big study because of college kids, high school kids going to college, nationwide. An insurance company looked at all the kids who got the meningococcal vaccine, and there was not an excess increase of GBS to that vaccine.
Good morning. What are any special considerations for people with CIDP undergoing surgery and anesthesia in regard to use of muscle relaxants?
Yeah, so the general perspective is the muscle relaxants are relatively transient. We actually advise to try and not use them in a different disease, myasthenia gravis, where the muscle relaxant works right where the disease problem is at the nerve-muscle junction. The general perspective is that your CIDP should be as best controlled as it can be going into whatever elective procedure that you're doing. There's no compelling data that you shouldn't get a neuromuscular blocking agent, that it's going to worsen your CIDP. And so if your CIDP does get worse, your physicians can deal with it. So it's sort of what I liken to is a what if problem versus a what is problem. What is I need this surgery. What if my CIDP happens to get worse by some immunological trigger from the surgical procedure, then we'll deal with it. Versus, what if I get a problem, I shouldn't get the surgery? If you have an indication for a surgical procedure, you need to get it done. The advice is to try and have your disease as well controlled as possible. There's really no compelling data that anesthesia is going to cause a relapse.
Dr. Gorson, I actually have a question. I was diagnosed almost 4 years ago, and I think it's the million-dollar question, and I don't know if we've really covered it, but when I try to educate people on what I have, when I tell them I have CIDP, they always ask me, what causes that? What is, even if it's a general answer, because trying to explain, I can explain what I have, but trying to explain to them how I got it, I don't know what to really tell them.
Yeah.
I was basically healthy for 4 years before that, and then bang.
Really common question, a natural question. What did I do to bring this on? Or why me? Or along those lines. The short answer is unknown. Really, we don't know. And if you think about it, the overwhelming majority of diseases that we see, we don't know. I mean, clearly, in some diseases, there's a hereditary factor that predisposes people to certain diseases. So certain autoimmune diseases can run in families. CIDP is not one of them. So it's not something that we see, nor is Guillain-Barré in general, for that matter. There's a few rare exceptions out there. So the short answer is we do not know why your immune system decides to do this. But that's actually often the case in a lot of other diseases, in autoimmune like lupus, for example, or rheumatoid arthritis or things like that. We don't know what the triggering factor is. And it may be that you have some genetic predisposition that's yet to be identified. It may have been some environmental exposure that we have not identified. As of now, there is no known environmental exposure, or some weird virus, but there's never been a virus linked to CIDP. And so the short answer is to be comfortable with the fact that right now, we simply don't know why people get this disease. It's the same issue, I often wonder, 20% of people who get lung cancer never smoked. Why do they get lung cancer? Secondhand smoke, urban pollution, genetic predisposition? I don't know. So I think the easier thing to do is trying not to broach it with friends and colleagues, because it leads to an extended and frustrating discussion.
I guess like along the same lines, what about, we talk about our autoimmune system. Where does, is there a gland, an organ? Is it like interstitial? Where are the
Where does it live? Where does it live?
Yeah, and who creates, or what part of my body creates that?
Your bone marrow.
So it's actually in my bone marrow?
It's in your bone marrow and your spleen to some extent, and lymph nodes and the thymus gland.
So it's actually in multiple places.
These are multiple different places that are relevant at various times during age and development. But classically, your immune cells are created in your bone marrow. That's where your white blood cells come from. Within white blood cells are lymphocytes, and there are plasma cells. And in the lymphocytes, there are B lymphocytes and T lymphocytes, and there's dozens and dozens of them, and each of these then modulate the release of smaller molecules called cytokines, and all of these things sort of interact with one another. So there are different cell lines, and each cell has a specific role to play in your immune response, and it's extraordinarily complex.
My daughter would be mortified that I would even ask this question, but I'm going to anyway. This is not my daughter, by the way. My daughter is actually dating a guy, and his dad has GBS. I've already introduced my situation. Are they if something were to happen with the two of them, are they at greater risk of having offspring that might have either of the above?
Yeah, so the short answer is absolutely not. So there was one paper that was published by the Dutch many years ago that actually showed the concept exists that there can be familial forms. So they identified a family where grandma had GBS, son had GBS, granddaughter had GBS. So clearly there is some predilection. And there is data that something called the HLA antigen, which has to do in some extent with genetics, is related in the immune response. But the short answer is GBS is an acquired disease. Mm-hmm. And so there is an interaction between the host and the immunological trigger. So a great example that I like to think about is we know in Guillain-Barré syndrome that one of the triggers for Guillain-Barré, well established, is a bacterial infection called Campylobacter jejuni. Campylobacter jejuni is a bacteria that one can acquire from uncooked meat, particularly chicken, okay? And there are outbreaks of it. So the story would be this. 20 people go to a cookout, okay, of uncooked chicken. They all eat the chicken, right? 10 people get a really bad gastrointestinal illness because they're infected with Campylobacter jejuni. So they have nausea, vomiting, diarrhea, they're sick as dogs. The other 10, they got exposed, they didn't get sick at all. Don't know why. Of the 10 people who got exposed to the Campylobacter jejuni, one patient gets GBS. what's special about that patient and not the other 9? There's clearly a host issue going on that something on the myelin epitopes that line the nerves of that one individual looked like Campylobacter. And when that person made an antibody response to the Campylobacter to kill the bacteria, that's a normal immune response. Those antibodies saw the lining of that person's myelin as looking like that Campylobacter and interacted with it, bind to the myelin, demyelinate it, and gets GBS. That's not necessarily heredity, but there is something about that particular individual that made them predisposed, right? So the short answer to reassure you is the statistical likelihood that your grandchildren will ever get GBS is identical to the general population of the risk of GBS, which is about 1 to 2 people per 100,000 individuals.
And there's no way to prevent it, GBS or CIDP. However, where that was said of me being the 1 in the million, could I have a reoccurrence of if I ate something like a bad piece of chicken again?
Yeah, so that, the question is, what is the likelihood of recurrent Guillain-Barré? So the first point to understand is that in the overwhelming majority of patients, it is a single one-time event that they usually recover from, and it will become a line item in their past medical history. They will go on through their lives, and it'll be, your doctor will say, tell me about your health. Oh, I had Guillain-Barré 10 years ago and recovered from it, maybe not to normal. That's the typical. There are very rare cases of what's called recurrent Guillain-Barré. It's well known, but extremely rare. We can't even quantify it. It's so rare. It's case report material. I have seen, I think, 2, maybe 3 patients in my career who've had a second or even third bout of Guillain-Barré over a 30-year history. So when I saw them for their second bout of Guillain-Barré, they said, I had Guillain-Barré 10 years ago, made a full recovery, and now they had bad Guillain-Barré when I took care of them. And then they came back 10 years later with the third attack. I mean, it's rare as hen's tooth. It's nothing to be concerned about.
I try not to let it define me, but I do fear chicken now and then. But I eat it.
Just make sure it's well cooked. So the question is, why is my foot drop symmetrical? And the answer is because CIDP and Guillain-Barré, they are symmetrical diseases. There can be a slight asymmetry side to side, but it's very common where if you have foot weakness on one side, you're going to have a similar degree of foot weakness on the other side, because it's not just one nerve that's being affected. This is a disease of the immune system that's affecting all of your nerves, but to varying degrees. So some nerves can be completely spared, others mildly affected, others severely affected. But it just so happens in this clinical syndrome, if one nerve on one side is affected, the other nerve on the other side tends to be similarly affected. It looks like we covered everybody's questions. Fantastic. Well, thank you very much for coming today. I hope this was helpful for you.